Thank you for joining me today. I'd like to speak to you about the role of reduced intensity conditioning in pediatric stem cell transplantation. As many of you are aware, with the advent of stem cell transplantation, a major problem has been the identification of approaches that reduce the toxicity associated with the procedure. This toxicity takes three forms. First is the toxicity of the conditioning or chemotherapy and radiation that is required to establish donor engraftment post-transplant. The second is the ability to reduce infections in the transplant host. And the third is the reduction of the significant transplant-specific toxicity, graft versus host disease. Approaches by many individuals, particularly in the adult arena, have identified approaches which do not require myeloablative conditioning, such as 12 gray of total body irradiation, high doses of cyclophosphamide or busulfan as approaches, and utilizes more an immunological approach to this strategy. This is demonstrated in part by a young child that I'll describe first here. I saw this child several years ago. He was 2 months old. He was a firstborn. He had persistent fungal infection since birth. He had a high fever. He had low blood pressure and was pale. He had a low white cell count. But when one looked at the lymphocyte count, essentially there were no lymphocytes. And his immunophenotype was that he had no T cells, but he had a few straggling B cells. This is classic of a condition called severe combined immune deficiency. And in fact, this child had common gamma chain SCID. Unfortunately, he had no sibling donor, and his options were either to have an engineered graft from a non-identical donor or an umbilical cord blood transplant. The second thing that had to be decided was whether we should use a standard myeloablative regimen or try a different approach to a transplantation. So first of all, one needs to understand we decided to move forward with a parental graft, a haploidentical half-match graft. And one has to think about why do we need to engineer this graft? That's shown on this slide here, because if one doesn't engineer the graft, you get this problem, graft versus host disease, with severe skin defects which can look like a third-degree burn and which can only be ameliorated by removing the T cells from the graft. However, one also has to be careful not to remove stem cells from the graft. Here is an example of a stem cell. These are very rare cells, and one needs to transplant large numbers of these cells to be effective. So we developed an approach in collaboration with the Miltenyi and the Cunningham system, where we were able to identify how to purify large numbers of stem cells or CD34 positive cells and remove T cells from the graft. And that's shown in this slide here. The three cells that represent the stem cells have that little red dot on their surface. And that little red dot actually represents antibodies that are on the surface of the cell, which are actually linked to an iron particle. That makes them magnetic. When one passes that through an electromagnet, the stem cells stick to the side of the column, whereas the T cells, which are the cause of graft versus host disease, are removed. This allows us to enrich large numbers of cells from the graft, and we were able to give this child 50 million CD34 cells per kilo. The average we would usually use is 2 million per kilo. This allowed us to significantly advance the idea that he would not reject the graft, that it would replace not only some of his hematopoiesis, but specifically his T cells, and would reduce the chance of graft versus host disease. So one releases the magnet and gives the patient back the stem cells. So what happened to this young man? Here he is 3 years later. He's doing very, very well. He has no problems, and he is fully engrafted with normal T cell function. Remember, at birth, he had no T cells at all. An interesting story about the procedure was that while he was in the hospital, his mom came to me one day and said, "You know, doctor, I've got a problem." I said, "Well, what's your problem?" She said, I'm pregnant, and I said, that's not a problem. We'll be able to sort it out if there's a problem. So she carried the child to term, and we identified by chorionic villus sampling that he had common gamma chain SCID. We transplanted the other child 3 days after birth, and here is his brother, and they're both completely engrafted and normal. This shows not only the power of transplantation, but it also demonstrates something else. You may notice that I didn't mention whether this child was conditioned. This child was not conditioned at all. This child had no chemotherapy, no radiation prior to transplant. And that's because the immunological system of the donor, the parental graft, had an advantage over the child's defective immune system and was able to reconstitute. This illustrates that being able to manipulate the immune system of the recipient may be an approach that we can actually utilize in more than these very rare cases of immunodeficiency. This has become important as more and more children with more and more problematic diseases require transplantation. As shown on this slide from the National Marrow Donor Program, in the last 30 years, there has been a steady increase in the number of children who've required transplantation. Associated with that, obviously, is a potential incidence of increased toxicity and increased failure from the procedure, particularly when utilizing cord blood, as shown on the right-hand side of the slide in orange, where there are significant issues related to rejection and graft versus host disease. So what diseases could be cured by transplantation? Well, a semi-full list is shown here, includes tumors such as leukemias, lymphomas, familial histiocytosis, bone marrow failure syndromes, immunodeficiency states that I've just talked about, and metabolic storage diseases. And all of these are treated every day here at the University of Chicago Medicine, and therefore we have to identify ways to be able to treat all of these children effectively. So what are the objectives of a transplant procedure? Well, there's 3 objectives if you think about it. One is we have to selectively and completely kill the normal bone marrow, the immune system, and if there are tumor cells, as in patients with leukemia and lymphoma, we have to kill those tumor cells. We then have to replace the absent bone marrow from the recipient with allogeneic hematopoietic stem cells. And then in the context of malignancy, we may have to activate the new immune system to actually take care of any residual malignancy. So with that approach, but with a standard approach, we now see approximately 50% long-term survival, maybe 60% in some situations. This is with all comers using matched unrelated donors. Here are similar results, just looking at our results with acute myelogenous leukemia and myelodysplastic syndrome. But many of these children either are in poor shape at the time or poor performance status at the time of transplant, or they do not have a matched unrelated donor or a matched sibling donor, and therefore reduced intensity approaches have been considered. So what's the rationale for reduced intensity conditioning? It's shown on this slide, and essentially it's taken from studies of looking at graft versus host disease. Graft versus host disease is caused by donor T cells. The donor T cells attack target tissues such as the skin, the gut, and the liver. They also attack the tumor. That's called graft versus leukemia. But also, we know that they attack recipient hematopoietic cells. So if one can use the donor cells rather than conditioning as the agent to destroy the patient's own bone marrow, therefore one will create a niche for the new stem cells that have been brought in with those T cells. That allows us not only to be able to transplant many more children, but hopefully with reduced toxicity, and it also provides a platform for graft versus leukemia treatment. So here is the principles associated with reduced intensity regimens. Essentially, we take stem cells from a donor, the donor is in green, we inject them into the recipient, and over time, the donor becomes a chimera. That's that old Greek word which means a mixture, and there's a mixture of the patient's own cells and the donor cells. By manipulating the environment so that one induces the donor cells to have an advantage, one can destroy any residual recipient cells and thus create a full chimera, which is the donor chimera as shown in green on the right. This approach has been very effective in adults with many diseases, and different regimens have been developed, including those on the left, which are called minimal intensity regimens, and those on the right, which are the ones that we tend to use, which are reduced intensity regimens, which usually contain the drug fludarabine with either cyclophosphamide or melphalan, and usually a highly immunosuppressive antibody, either anti-thymocyte globulin or Campath, those two antibodies having the same property that they're able to destroy large numbers of T cells, allowing the recipient, once treated, to be essentially tolerant to the incoming graft. So what is the pediatric experience with reduced intensity conditioning transplant, or RIC type transplant? Well, I don't have time to talk about all these in this session because there's been a lot of different studies, but this is one study from Stram and colleagues several years ago in which they used a fludarabine-based regimen, and they showed effective engraftment of peripheral blood stem cells with outstanding overall survivals and event-free survivals. However, there is a significant problem with these approaches. One is there's a high rate of graft rejection. Secondly, there's a high rate of chronic graft versus host disease. And the third is that there is problems with viral disease post-transplant. To address this approach, we at the University of Chicago Medicine, in collaboration with our adult colleagues, have developed a new approach called the haplocord transplantation approach, in which we combine both the short-term effectiveness of haploidentical transplant, in which neutrophil and platelet engraftment occurs quickly, thus protecting the patient from peri-transplant infection, with the long-term effectiveness of a cord blood, mixing the two grafts together, which allows the cord blood to be the dominant graft long-term, and this reduces the risk of graft versus host disease, which is high in the context of haploidentical transplant. We've developed with our adult colleagues an approach in which we use three agents, fludarabine, melphalan, and ATG, as a conditioning regimen with post-transplant GVHD prophylaxis with tacrolimus and mycophenolate. And we've been able to determine in over 80 patients that we see stable engraftment in virtually every single patient. This is a major advance as it has reduced the risk of graft rejection, which is seen frequently in the context of cord blood transplantation alone. Not only that, but our outcomes in a very high-risk group of pediatric and adult patients has demonstrated that we have similar outcomes to the outcomes that we observed with matched unrelated donors and matched sibling donors in the context of leukemia. So we continue to work on this strategy. We believe that the next steps with this strategy is to place on this platform post-transplant anti-leukemia immunotherapy, and we're working with our immunology colleagues here at the University of Chicago on several new studies that will open this year, which hopefully will improve these outcomes even more. However, this approach also allows us to address another issue which is relatively unique to pediatric transplantation. That is, how does one transplant effectively and safely for children with non-malignant diseases? These are diseases that are still lethal, but frequently are chronic and may take many years to demonstrate their poor outcomes. We've thought about this in the context of hemoglobinopathies, immunodeficiency, bone marrow failure syndromes such as Fanconi anemia and severe idiopathic aplastic anemia, in cytopenic states, and even in metabolic storage diseases. Now, we have a high bar to overcome. Our transplant outcomes, for instance, in severe sickle cell disease are outstanding with greater than 90% survival. Not only that, but we see outstanding outcomes in the context of correction of neurological deficits in these diseases. We have in the past looked at haploidentical transplants alone for patients with severe sickle cell disease, and as shown on this slide, we see outstanding outcomes with greater than 75% long-term survival in an extremely severely affected cohort. However, we have decided now to move to a reduced intensity approach given the results of our experiences in the context of malignant disease. And again, we're going to use the same strategy as we used in malignant disease with a fludarabine, melphalan, and antithymocyte globulin approach. We're going to mix both stem cells from a haploidentical donor and a cord blood donor, and we're currently shortly going to open a study that will look at these diseases: sickle cell disease, lysosomal storage disease, aplastic anemia, congenital cytopenia, and non-severe combined immunodeficiency SCID. These diseases remain critical problems for the children that are affected by them. We believe that this approach has the potential to significantly not only ameliorate the phenotypes associated with these diseases, but actually cure many of these children. In a final couple of minutes, I just want to review again the child who I talked to you about at the start. This is a child with severe combined immune deficiency. So what do we do for those children? Because they don't need chemotherapy conditioning, even of the reduced intensity variety. They require high numbers of stem cells. And so if one looks at the largest national studies performed by Rebecca Buckley in beautiful, elegant studies at Duke University, she's shown with non-myeloablative approaches that a 74% survival at 3 years with a non-conditioned transplant. That's this data here. And she's also shown effective reconstitution of the immunological function as demonstrated by this slide of T receptor excision circles. However, she has seen a significant incidence of graft versus host disease, and many of these children still need intravenous gamma globulin for B cell dysfunction. What is our experience? In our combined experience between my time at St. Jude Children's Research Hospital and since coming to the University of Chicago Medicine, we've transplanted 23 patients with SCID, 5 matched sibling donors, and 18 parental grafts. And we've seen outstanding results with greater than 80% of our children surviving long term. This suggests that a different approach is required for severe combined immune deficiency in contrast to the other non-malignant diseases. It also suggests that there will be context-specific approaches to transplantation for different diseases over time. In other words, a personalized transplantation approach, which we are taking here at the University of Chicago Medicine. So in conclusion, reduced intensity transplant can play a significant role in cure of both malignant and non-malignant diseases amenable to transplant. Unfortunately, we still have some viral disease and relapse being significant causes of morbidity and mortality. But fortunately, the incidence of graft versus host disease does not preclude the use of this modality in non-malignant disease, thus expanding the potential options for children with these chronic, devastating diseases. I want to thank you for your attention.